Welcome to another edition of You and Me and Multiple Sclerosis. My name is Pam, and I've been living with multiple sclerosis for 37 years. I started this channel partly to get conversations going, but also I just wanted to share some of the resources and information that I found helpful as I was looking into different aspects of multiple sclerosis. And I have to say that I very quickly got pretty well overwhelmed. There's a lot of information out there. As you know, when I was first diagnosed, there really weren't very many therapies available. And then I was on Copaxone for 10 years, and then after that, I went into secondary progressive and no medicines were available for that. So then we were doing symptom management, basically. I guess I still am. But there's a lot going on, and I just was curious about it because I thought, all right, in my lifetime, am I likely to see anything that's really going to help people in my stage of the disease? The short answer is we don't know, because you just never know, right? Breakthroughs are called breakthroughs specifically because they're not really expected. They just break through. And I'm thinking that that could happen at any time. But I decided in the course of looking at all the different medications and therapies that were available and getting kind of confused, I thought, okay, I'm definitely going to be doing a video for you that tries to untangle some of that. But in the meantime, I ran across a number of medical professionals, academics, who have some opinions about the future of multiple sclerosis research and treatment. So I decided that I would just let them speak for themselves. And what I'm just going to basically do is introduce them and let them talk. But then I'm also going to be putting the links to those presentations down in the description box below so that if you want to see the whole thing, you certainly can. The first person that you'll be hearing from is Dr. Wallace Browne.
I think one of the biggest challenges facing all neurologists treating MS at the moment is this dizzying array of treatment options that we have available. And I think increasingly, as we've heard already in this panel discussion, this concept of first, second, third line is maybe not the right way to be going. And actually, we've got to try and tailor our therapies to the patient, depending on their disease profile, the number of relapses, what their MRI is looking like, what their level of disability is, their comorbidities, desire for family and planning and things.
Well, that was pretty interesting. So let's hear what Dr. Raymond Roos has to say.
In the old days, we had lymphocytes. Now we have B cells and T cells, and now we have kinds of B cells, depending on the markers in them, kinds of T cells, depending on the marker. And I think we're probably, on page 10 of an 1,000-page book. We don't really know the immune system as well as we will in the future. And we need to target things in a really discrete, focused way. I mentioned all of these drugs, so many of them target the immune system, but they do so in a rather blanket way. They're not quite as refined in general as we would like. We miss the target that we really want, which is, oh, you have MS number 67, and I'm going to give you drug A or B or whatever. We do that to a certain extent in some of the cancer treatments, but we're far from that in MS.
And now this next clip is from a presentation that was given by two colleagues who are working on a therapy together. One of them is Dr. Benjamin Greenberg, and the other is Professor Anthony Traboulsee. I hope I pronounced that correctly. They also are repeating a lot of the same themes. I think you're seeing a pattern, right? Let's take a look at what they have to say.
We're used to our medications being one size fits all. It's one dose of ocrelizumab, one dose of interferon, or what have you. And we might have to look at strategies of personalizing the dose, depending on the individual's pharmacokinetics.
And that's something that we have completely lacked in the field of multiple sclerosis. So, I look at my colleagues in stroke who look at platelet activating factor assays. They follow an INR with warfarin and they personalize a dosing around the biology to get the desired effect we want. We have never had that in multiple sclerosis. And it'd be really nice to have a drug where you could personalize the dosing around some sort of biomarker that had clinical implications.
So there is basically a theme that we have many different kinds of therapies, many medications. Now, what are we going to do with this plethora of stuff? And how can we make the outcomes better? How can we make the patient experience better? One of the things that I thought was interesting was a presentation that I ran into by Dr. Stephen Krieger, who has looked at different medications and perhaps how they might be tailored to fit individuals a little better than they do. So let's hear from Dr. Krieger.
There's a huge acceleration of therapeutic options in multiple sclerosis. We like to think of our field as the trendsetter for neurology, becoming a disease treating specialty as opposed to just a diagnostic specialty. Sometimes we see an MS patient that really worries us. She has innumerable lesions, brainstem lesions, spinal cord lesions. She's developed weakness, cognitive deficits, and we want the most efficacious medicine we can to try to shut that disease process down. What the neurologist is then doing is reshuffling this deck of options, prioritizing the most effective medicines that we have, and then choosing amongst them on the basis of risks and side effects and comorbidities. So that's one example. Sometimes, however, we see patients who have incredibly mild disease. They have maybe 1 or 2 lesions. They had a mild optic neuritis that recovered fully. They are neurologically 100% normal, high functioning, low lesion burden. And we can prioritize a safer medicine, one that might not be as effective. Similarly, we might do this for a patient that has MS, but also many comorbidities. Because if someone has cardiac disease and pulmonary disease and other autoimmune conditions, we might want to prioritize the safest of our medicines. And then basically, we're shuffling our options in a totally different order. What you can kind of get a sense of here is we have soft biomarkers for how we choose these medicines. What we don't yet have are genetic predictors of disease response. We don't have molecular assays to know who's going to respond to which medicine. We're not there yet. And so there are no protocols, which can be quite frustrating for many people in our field.
And then finally, I have to end with Dr. Gavin Giovannoni because he always has some good things to say on the subject. And this is a presentation he gave back in 2020, a little older maybe than some of these other ones, but his words are still as relevant, I think. And after hearing what all the other folks had to say, I think you'll probably agree with me on that.
So a long way to go, but I think people with multiple sclerosis should not be negative about this. We've really come a long, long way since the early 1990s when he had no treatments. And we're beginning to actually talk about therapies where we are actually causing restoration of function. And there are some trials going on now with remyelination and neurorestorative therapies where back in the 1990s that would have been considered science fiction. So I think the innovation cycle has moved quite rapidly. I mean, for people with MS, they may say that's too long. But I think, in terms of where we were 20 years ago, 25 years ago, we really come a long way.
Well, I appreciate what I've learned from all of the presenters. It's going to help me, I think, as I put together the video that I'm doing for you on all of the drugs that are available to us now to treat multiple sclerosis. I hope to get that video out pretty soon. But that's all I have for you today. Take care, and I'll see you again in my next video.